Good day, as we would say in Australia. Although we don't actually say that at conferences, but I feel compelled to say it here. So myself and Shannon are going to do a bit of a tag team. I'm going to introduce. She's going to glare at me if I go over my allocated intro minutes. Then she's going to come up and then I'll wrap up. So as you can see from our title, we're talking about housing first as a pathway to improved health. And I think as a really nice, not that we anticipated this, but given we've just all come out of a session where a really strong focus on lived experience and the voice of lived experience. And so we had already decided back home that we wanted to start with a quote from one of the participants in the Housing First project. And what she's really alluding to there, and I'll explain a bit more, is just in her own words and unprompted, talked about the benefits for her of three different services, the housing side of Housing First, the homeless healthcare GP and the community service with her caseworker coming together and really facilitating things that would not happen if it was just all fragmented. So just for a bit of context, there's been a lot of stats over the conference about homelessness in the UK, but the Australian context, we also have rising homelessness. This is our state, massive state over here on the right. And that's the figure from our census, 2016, in terms of homelessness. Rough sleeping in our state, and as with the UK, we very much acknowledge that homelessness comes in all shapes and forms. But the Housing First project that we're talking about today is particularly focused on rough sleepers and the most vulnerable of rough sleepers. And as Nigel alluded to in his question time, I'm ashamed to say that our Aboriginal people, who make up about just over 1% of our population nationally, actually comprise 29% of homeless people. So that is something we are not proud of. It's well known. I think what's been interesting for us being here is just to see how many similarities there are in terms of the health profile and needs of people who are homeless. So these are some stats from our data in Australia, and we've just noted there that there are a lot of similarities, but also some differences. So Amanda Stafford, in her presentation yesterday about the Royal Perth team, mentioned that the UK is fortunate because you don't have the scourge of meth that we have, and so I know there's other drug issues here, but meth is really taken a hold amongst our homeless population, and lots of consequences of that. And sadly, some people using meth as a way of keeping awake on the street to stay safe. We have some other issues, exposure to sun, heat for rough sleepers. Here you've got the cold. We have, just that exposure to sun and skin cancers. And so one of the people in the Housing First project, because of an undetected skin cancer, had her leg amputated at the knee. And the heartbreaking thing for her, and when she was telling me about it, was that when they told her they had to cut off her leg at the knee, she said, "How will I run away on the street when I don't feel safe?" So skin cancers is a big issue. And also we're such a spread out country, so the issue of access to health services in our remote areas. So also in terms of context, we have a long wait for social housing, public housing. Again, lots of parallels to the lack of affordable housing in our country, and even longer in regional remote areas. And that quote there is from a person I spoke to just last week who was telling me about her daughter in Kununurra. So Shannon's put a fun fact there about how far Kununurra is from Perth, waiting 10 years for public housing. So again, it seems like a theme in my talk is things that we're not so proud of. So what is homeless healthcare collaboration the West Australian way? So, we tried to get Amanda to put a quokka into her presentation. She wouldn't, so Shannon and I have included the quokka, which is an iconic part of Western Australia, but we're not just about quokkas. But we hope that some of these scenery shots do entice you to come down. So what we're really talking about in this paper is the collaboration between inner city hospital, so Royal Perth Hospital, it's in our inner CBD, it sees the most homeless people of any of our public hospitals, a specialist homeless GP practice, and the Housing First project and a university. And we have the unique position of we are the kind of evaluation and fan club for homeless healthcare and the Royal Perth Homeless team, but Shannen and I also lead the evaluation of the 50 Lives Housing First project. And so we basically, for this presentation, have joined up all our kind of collective evaluation work to talk about how they're working together. So I'm just going to go through what the 4 services are and then switch to Shannen. So homeless healthcare is a GP practice, or GP++, as Andrew Davies now calls it, because we're increasingly expanding kind of beyond just the GP. There's nurses and other allied health services coming under its umbrella, and very influenced by the work of Jim O'Connell and then later Pathways in terms of the model that's been set up there. And you can see that there's kind of the whole gamut from street outreach to after-hours services to taking clinics to various community-based centres. We have the Royal Perth Homeless team, so Amanda from there is up in the picture. That was set up mid-2016 based on the Pathway model. We're touting it as the first Pathway team in the Southern Hemisphere, and hoping to see some others in Australia soon. So the team has the GP inReach. Amanda just spoke yesterday about the most recent evaluation report. So now the team has seen over 1,000 people who are homeless in its 2.5 years. And really central to what we're talking about today is that in the Perth model of Housing First, the health through the Royal Perth Homeless team and Homeless Healthcare are really key players in the Housing First project. So they're on the steering group. Amanda and Andrew sit on the working group, and Shannen will talk a bit more about that. And also in the evaluation of 50 Lives, which is our Housing First project, health is one of the main outcomes they're looking at, and reductions in health service use. So I think some of the things I've been hearing about Housing First initiatives across the UK, they seem to vary in the extent to which health is a presence. But in our iteration, I think we're really pleased to say that health is front and central. So this is 50 Lives, 50 Homes. They, I guess they set themselves, in hindsight, they set themselves a conservative target in calling it 50 Lives, 50 Homes, because in the time that it's been going, there's now been 192 rough sleepers housed, but they already had the logo and the name, and so it continues to be called 50 Lives. And so it's a collaboration of 28 partner organisations. So we've got up there, so it's your usual kind of suspects of community housing, government housing providers, health, as you can see. We've got Aboriginal service providers as part of that. Police, which is another really unique thing that we have. We had a high-level person from police as part of this, and so there's this collaboration, and RUA is a community-based organisation that is the backbone. And so for those of you who are into kind of collective impact models, having a backbone organisation has been really central to do some of the coordinating of this. And then the 4th service that we're talking about today is the after-hours support service. And this is something funded by our primary health network to support those people who have been housed from 50 Lives. And this is this critical thing about it's housing first, but not housing alone, that the wraparound support being provided to people once they're housed. And because the people being housed are they're really vulnerable. Some of them have been homeless for 20, 30 years, complex issues, trauma, drug use, they've been incarcerated, the whole gamut of complex issues. And so the After Hours team has a homeless healthcare nurse and a RUA support worker go out in the evenings, and it can range from a whole lot of things, like checking on how someone is in terms of their overall well-being, talking to them about their medications, checking on a wound, assisting them with cooking, the whole range, and really a lot of it is that kind of mental health and other support embedded in also just human contact for people who are quite isolated once they're removed from their street environment. So I'll hand over to Shannen now.
Thanks, Lisa. So for the purposes of today, I'm going to limit it to just 4 things that they've been able to achieve through the collaboration. We could probably talk up all day about how these groups work together to achieve both improvements in service delivery but also outcomes for the clients, but I'll just give you a little taste of what they've been able to do. So one of the key things as part of this project is by having people like Amanda from the homeless team represented on the Housing First committee, they've been able to refer people directly from the hospital and advocate for people that are highly vulnerable and have little support to actually get accepted into these types of housing programs. So for some of the ones that are really highly vulnerable, this is 50 Lives of Housing First program, but there's also pathways to get into other transitional housing accommodations. And what we've found doing this work as well is that over time, Amanda's team now sees about 70% of clients that aren't known to any services at all. So it's a really highly vulnerable group, but they're falling through the cracks. They're not getting support from anyone else. So this provides kind of a key conduit to link in with other services, and health kind of provides that gateway for that, whereas, you know, if they might not feel comfortable approaching a service or everything else. So health really has provided that endpoint to help get into housing. So an example of this, Curtis, not his real name, you know, highly, like trimorbid, really high length of time spent homeless, really high presentations to the emergency department, or A&E as you call it, sleeping under a bridge for 26 years. In his discharge notes, he was often discharged as not having an acute issue or no treatment provided. In one of the notes, it actually said he had been given a taxi voucher to return to the bridge he was sleeping under. So as part of the development of the homeless team in the hospital and 50 Lives, they were able to, you know, sit down and do the VI Spit Out, which is the tool we're using to assess eligibility for Housing First. Able to do this, demonstrate they're highly vulnerable, but Amanda's then also able to advocate and show that this person needs housing and support. And through this program, he was housed about 2 years ago in an aged care hostel and still remains housed with the support provided by the caseworkers and primary care GP services. So it's kind of an example of someone that was presenting high to the hospital and being able to divert them away from the hospital and into supported care. So another example of what the collaboration's been able to achieve is linking people in with primary care. So for part of what Lisa described with the after-hours service is that they're going into people's houses or providing that additional life support, and what it's able to do is you're able to streamline and connect people to the services, and it helps keep individuals in their houses. So another little case study. This is Kathy. So this is actually the lady who had the leg amputation resulting from skin cancer. So she had high hospital use again, had been engaging with the homeless healthcare GP service from a few years ago, but what the after hours team's been able to do is, now that she's in the house, they've been working on her anxiety by linking her in with community services. So I don't know if you've got the equivalent of TAFE here, but it's kind of community college, thank you. They've been able to get her into art courses and let her explore some of her passions, which help with her anxiety, and as a way in to help address some of her family reunification processes that she's going with. So by being able to take the time and build relationships with these people outside of a hospital setting or outside of a drop-in centre setting, they've been able to build really good trust, and as a result, get them be able to develop on other issues. And especially for Kathy here, last year she was actually nominated for an award at a national level for some of her art, which is incredible for her. Another thing we've been able to do through the collaboration is reductions in the hospital usage. So this is just for a sample of 44 people that have been housed through 50 Lives, 50 Homes. But what we've seen is for these individuals, a year after being housed, there was fewer people attending hospitals, fewer people being admitted in inpatient wards, and for the people that were returning and still going to hospitals, they were actually going fewer amounts of times. And what we've found as well is that, I don't know if Amanda mentioned it yesterday, but that we've gone from having about 80% of the frequent attenders in the Royal Perth ED being homeless to about 30%. So in the 2.5 years that this service has been operating in the hospital, there's been a big shift away from it being people experiencing homelessness as the highest presenters. So Wayne here, he had very high hospital usage, I think it was about 30 times a year or so for a period. What they were able to do by engaging him with the 50 Lives program is able to stabilise his psychosis, get him on the depot and eventually get him housed, and they were able to link him through a street doctor and through the hospital. But what was quite amazing about this case study is that when he lost his house, his hospital use didn't increase because they had built relationships within the primary care setting, that he trusted the GPs that he was working with, that he continued to get his depot even when he'd lost his house. He's now been rehoused again, but I think by having multiple organisations working together and being able to take that time to build the trust, that even when something goes astray, there was still better outcomes for him. And just a final little point to finish on. Over the couple of years that the team's been working in the hospital, there's also been quite a shift in the culture of how other clinicians both approach homelessness but also approach the team. So what we've seen is that increasingly they see the homeless team as a resource to refer to. They've got access to other resources that they didn't have before. You're able to link in with housing, and as a result, you're not seeing the same individuals and the same frustrations of coming back to the hospital. So there's kind of been that culture shift within the hospital and support for the team. So I'm going to pass back to Lisa just to quickly go over some of the success factors of why this has actually worked in this setting.
So we just wanted to highlight what we think are a few of the key success factors, and one up there is just that familiarity and the multiple points of contact. So Shannen and I, we don't like ivory tower research at all. So we've been out with the team, we've been to the hospital, we've been with Street Health, and it literally can be the same nurse that a person might see in the hospital. They might see them at the Street Health van. They might see the same GP at the clinic week after week. So there's these multiple points of familiarity and trust, which is so critical, particularly when people have had trauma or bad experience with the health system. The client-centred collaboration, and I think one of the things we really want to highlight is that, yes, there is a formal kind of partnership agreement in the 50 Lives collaboration, but actually what works on the ground is all that informal stuff. And so just... and we see it in action, and we see it ourselves in the evaluation, just being able to pick up the phone, the way people know who the services are that are going to be amenable, that the kind of really chronic rough sleepers are known, and people can advocate for them at a human level, and it really cuts through a lot of that, your bureaucracy. And Shannen went to one of the working group meetings, and an amazing example of, like, here, I don't know what your equivalent is, but Centrelink, which is where you get all your unemployment benefits, and normally it's a nightmare. I can't even deal with it. I've been red flagged because I got so cross. So, and you spend hours on the phone, you can't get through. And Shannen went to a meeting where Centrelink was there, Amanda was there, other services. Amanda whipped up her laptop, Centrelink said, we can do that straight away, which is unheard of in Australia. So it's that kind of thing about just cutting through the red tape and doing things differently. Which is what we're talking about here, is just that rapid problem solving and really just trying to, which we don't use the language so much, critical time at the moment in 50 Lives, but really that's what a lot of this is. And I think the other thing that we find really amazing in evaluating in this project is seeing that Amanda is a busy clinician in the hospital setting, and Andrew Davies from Homeless Healthcare, like we see with Jim O'Connell and Nigel Hewitt and others, they're equally passionate about reforming the kind of policy space, and I think really critical and of value is that they have been invited to the table literally by these really high-level kind of committees and policies around ending homelessness in our state. Just a 1 second kind of shout out to the fact that there's a very kind of symbiotic relationship between research and practice in this project, and I'll just click through these. But I think one of the benefits we've tried to bring to the team is that we're not just evaluating it, but actually using that to do things that will then reinforce the work of 50 Lives and the homeless health services. So whether it's been advocating when they run a service is going to be defunded, I got to appear at a Senate inquiry about homelessness, and now increasingly we're using the evaluation not just to show what works, but to say here's a gap. And so we recently got a $250,000 grant, which is quite big in our terms, from our health department to trial a service for people with dual diagnosis who are homeless. And that came out of the data that we've been collecting. And just to finish, to say that of course lots of things are rosy in Perth, metaphorically and literally when the sun's out, but it's not to say that there aren't challenges. And so I won't talk through those, but just to note that there are challenges in the collaboration. I think one of the key ones is really that getting people to leave their logo at the door, and that's what 50 Lives has achieved. It's not to say it's always perfect, but really that people just put aside whatever their kind of their organisation is, and while sometimes they're pitting against each other for government tenders, for this project at least, people do manage to put that aside. But I think precarious funding is an issue, changing the culture, the harder to fill gaps are going to be continuing issues that we have, and I'm sure are mirrored here. There's just some links up there. We have tried to get in time for the conference, all our kind of reports up on our various websites, and Shannon and I around, and Amanda if you want to have a chat. And Amanda has got some of our 4-page glossy about the Royal Perth Homeless team there. Thank you.
Thank you. Yes. So I was in Australia back in October, and I remember meeting a social worker who was an Aboriginal, and how she told me that often she's accused of being a traitor when she goes in to try and help some families that are struggling. So you do face some unique challenges in terms of, it's quite startling, the proportion of people affected. So that's an interesting one to explore. But I suppose yesterday, things that really came out that you just mentioned at the very end and are very pressing in UK are things like the fact that we're promising people that they'll have access to permanent accommodation, but then money runs out and pilots close down. So it's a big concern for people at the moment as we start to try and scale up housing first in the UK. So it'd be great to hear a little bit more about your experience in Australia. You seem to be doing okay in Perth. Any plans to scale up? The other thing that came out yesterday from Jim's talk, Jim O'Connell's, is that after 10 years of tracking people, the outcomes are very different from the many studies we have across the world that only track people for 2 years. So at the 2-year point, it seems as if outcomes are incredibly good, but then after 10 years, actually, success probably looks like 30%. And maybe that's okay. So maybe it's about us reframing what success should look like for this population, which happen in other social policy fields. So it'd be great to hear your comments on both those two things.
Maybe for the latter one first, and we actually were talking to Jim about that last night. I think that whole thing about, what it looks like at the 2-year point and then longer term is really critical, and Shannon is going to dedicate a big chunk of her next 3 years to a PhD looking at exactly that, and I think that's why we really value this kind of being quite a live evaluation, and with those, so that as we're picking up things where we see that people might be falling through the cracks. So we fed back from the evaluation, we fed back to Housing First project, for example, that, where are you picking up that people have already had, at risk of losing their tenancy? What's being put in place for that? So now they've got some better systems for tracking some of that. So not saying that will solve those things, but I think, I think we're really conscious in this that the research is trying to inform changing the way the project evolves based on some of those learnings that down the track. But I think you're right also that these, and from the speaker this morning about trauma, that and some of our Aboriginal people, you know, the stolen generation, that historical trauma, that just won't go away, and that's always going to be a legacy, and it's always going to be hard for them to survive in a house, and they have different notions of housing, and so I think you could be right as well about changing what our metrics are of success, because as Zana was talking about yesterday, you know, it might be that, you know, you're spending money better and in a more humane way. So yeah, I think the points you raise are something we're very, very mindful of.
But let's open the questions to the floor. Any questions? And we'll take a couple, 2 or 3 at a time. There's one raised hand there, and another lady over there.
Hi, I'm Jo from Bournemouth, and I've been running a Housing First service for about 5 years now. I was quite interested. It almost sounds like you're health-led rather than housing-led. So from our point of view, it's the house that comes first, and what we end up finding, and then nobody else wants to buy him. So I'm wondering, was that a purposeful thought when you got health involved as opposed to just the house?
We'll take another one over there. That lady.
Right. My name's Sue. I work in East London, and as everybody now knows, partnership is absolutely key to delivering these homeless services. You mentioned briefly one of the agencies that I think we don't traditionally partner sufficiently with, and that was your work with police, and you had a top police person involved. I wondered if you could just describe the role that the police actually have in helping you to deliver your service.
You can do police and I'll do the first one. So in terms of the first question, I think it still is housing-led. It very much is a housing first, and in fact, you know, even within the collaboration, sometimes there's frustrations, I guess, maybe from the health side about. I remember sitting at one forum, and Andrew Davies and myself were in the audience, and it was a lot of housing, you know, and so, but very much I think health has been at the table, and I'm sure that was partly strategic, but also I think the reality is if you go back to the housing first model, it has to be housing first with the critical wraparound support. And in WA, where the VI SPDAT drives who is housed most rapidly, it's all about markers of vulnerability in terms of health. So from our point of view, it would be kind of just a massive missing piece to not have health as an integral player in the project and how it unfolds, given that health vulnerability is a key driver of who gets housed. So I guess it's not that it's health-led, it's just that the health is seen as a critical part of the wraparound support. But I guess in some of the examples we've shown, and perhaps somewhat uniquely, is that health is also driving some of the detection of who's most vulnerable and getting them housed, and then really keeping them housed through that after-hours service.
In terms of the police, we were fortunate enough to have quite a strong champion within the police force. He's now moved to a different kind of sector within the police. But the importance of having them involved was that convincing, like on the ground, street patrol type police officers that there are better ways to deal with people than just, oh, you're misbehaving, you're doing this, whatever, lock you up. They're now working with the community, like caseworkers and community organisations, to say, this is a link, what's like their history, what can we do to better connect and engage, how do we improve both the safety of someone experiencing homelessness, but also of the police officers. And it's been kind of this synergistic relationship where you're increasing the awareness of the issue of homelessness for the on the ground people, and trying to change their culture and trying to change that, oh, they're just drunk, they're misbehaving, they're, you know, being abusive, they're this, that, whatever, and actually helping create that understanding that there's a lot of underlying issues, and to take different approaches to engaging with people and linking them with services.
Any other questions? Lady over there. Yep.
Hi, I'm Niamh. I run an intermediate care centre in Dublin with the Dublin Simon community. In regards to managing mental health in the community, so we'd have a lot of clients with trauma, with going to hospital, so they're refusing to go to hospital. So a lot of our clients would be step up into our service. And just how do we manage their mental health in the community? Can you give an example of like team members, like people on your team that manage mental health? And
that lady over there as well. Can you say who you are as well? Yeah.
Right, consultant in public health in Barking and Dagenham Council and Greater London Authority. Yeah, my question is about the housing aspect. So I wondered if you can say how it's funded and whether there are issues around eligibility, because that's one of the problems we have, particularly for people with no recourse to public funds, and then whether there's a sort of move on, or are people able to stay there sort of forever?
In terms of the mental health one, and I might flick to Amanda also, but certainly I think it would be fair to say that some of the people with really complex mental health needs they get a lot of the after-hours support, and that's really important. So when I went out with them one evening, two of the people we visited had high mental health needs and a lot of previous suicide, self-harming, other complex mental health issues. So just that after-hours support really important, but also connecting them, the GP's kind of care of some of their mental health issues, and I guess in starting this new service, we now have a half-time psychiatrist working with Homeless Healthcare, which is going to be really valuable for further supporting those people. So I think there's recognition that they are going to be some of the ones that it's harder to keep their tenancy, higher support needs, and one of the challenges for the project is as they house more people, a lot of people, the after-hours support service, it doesn't have a cut-off date, and the reality is that more and more people, as more and more people get housed, some are now not needing so much support, but others are just going to need that continually. But Amanda, do you want to add something about mental health?
So we face quite a lot of the challenges that often the most vulnerable mental health patients who are homeless often get excluded from a lot of the mental health services for various reasons. So the pilot that we're running at the moment is embedding mental health with the half-time psychiatrist and a full-time mental health nurse to try to actually bringing that co-located with the GP clinics in drop-in centres, so that they're not going to a psychiatric clinic, they're actually being seen within familiar surroundings for them. And so I think we're piloting that to see whether bringing a more specialised aspect, particularly for patients who have things such as psychotic illnesses, where there are questions about involuntary treatments, whether we can improve on that. But we're hopeful that we will be able to get to access a lot more people. And so we've got two big groups, one of the psychotic groups with psychotic disorders, and the other are people with trauma-related problems, such as borderline personality disorder.
Well, we're going to have to leave it there, but Lisa and Shane are going to be around all day, so go and get them, check out the website, and yeah, make the most of it. So thank you very much again.
Thank you.